Okay, and I'll just a moment and I'll be able to share and we'll have the PowerPoint up here. Okay, Dr. Dozier, I'm ready when you are, and you can just let me know when you'd like for me to go to the next slide.
Thank you. I appreciate you
Sure.
managing the slides for me and even fixing a couple of them for me.
Glad to.
Hello and good afternoon. It's Damon Dozier. I've been practicing at the VA since 2018 in chronic pain management. Interventional is a word that people use. I do minor minimally invasive surgeries, injection therapy, but also visit patients and talk about their disease process, medications maybe to treat it, where they've been, what they're doing, what they might benefit from. I'm the director of the ketamine infusion program at the VA. We do that for chronic pain. We'll touch on that a little bit later too. But prior to this, I was in solo practice in Clarksville for roughly 10 years. Now, today it's my privilege to be speaking with you and be representing Tennessee Pain Society. I previously was the president of Interventional Pain Physicians of Tennessee. Dr. Hilgenhurst currently has that, and he has also the credit to be the one to have started that chapter. On to the slides. I'm fellowship trained in pain. That means I did an extra year just to try to train in pain, and we can all argue that is not enough. But advance, please. So we're here today to kind of discuss what is chronic pain. So chronic pain and the things that follow, the sequelae. To get there, we'll need to differentiate from acute pain and discuss some management strategies and treatment of pain, treatment of opioid use disorder, and we'll kind of touch on those things through the next 20 slides if you're patient enough for it. So above, you can see acute pain is basically a protective function, right? It tells you something about your environment. That's what the body needs, some kind of signals, right? And typically acute pain will resolve after whatever insult heals. And as it says up in the slide, it's usually something that comes on acutely, suddenly, and it has a concise duration. Chronic pain, and I put in there specifically non-cancer chronic pain. We differentiate out the palliative care type of chronic pain from cancer and say, okay, chronic non-cancer pain, and it's usually considered a disease itself, although it may result after an injury or an illness, and it can be influenced by environmental and psychological factors. It's resistant to most treatments. Now, this is considered like a overall bullet slide to say we'll also touch on non-opioid medical treatment of chronic pain, opioid use disorder treatment, and buprenorphine, and then buprenorphine usage for chronic pain. Next slide. So in 2018, the International Association for the Study of Pain said, okay, we need to reevaluate our definition from 1979. And you can see the two definitions there. In 1979, chronic pain was considered an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. And that sounds like a mouthful of gobbledygook, but they're trying to achieve a big goal, right? And I'll touch on that in a moment. But after 2 years of deliberation, they basically changed it a little bit, right? It still says unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. Nonetheless, we won't go into grand detail of why the task force chose their wording, but some of the things they did say I found interesting. One of the things that they stated was pain can range widely in intensity, quality, duration. So defining it concisely is a challenge, right? Also, pain has a multiplicity of mind and body interactions, and a concise definition can neglect the ethical dimensions of pain. Also, to use the word unpleasant may trivialize the severity of pain. So ultimately, pain is more than a symptom. Chronic pain may be a chronic disease with its own clinical course. Next slide. There's some things I've got in these slides that may pop up a couple of times, and one of them is this statement is found on the NIH website that says 20% of the adult population in the United States has chronic pain. Many of these people are experiencing more than one type of chronic pain, and we'll get into some of the types a little later. For every 10,000 people with severe pain, there's only one board certified pain physician. This is a fact that's been stated in different verbiage, but nonetheless, chronic pain is diverse, and a board certified pain specialist would hopefully have broad reaching understanding, but also just having other subsets of the allied health understanding what chronic pain is really matters. I think we'll all agree on that. Chronic pain is a leading cause of long-term disability in the United States. Chronic pain is a biopsychosocial implication. It's not just the pain, it's, reduced quality of life. It's increased risk of anxiety and depression. So as I was researching some slides to put together for this, I bumped into this and was thinking how pain impacts your life. And I found it interesting. And you may have heard some of these. I've heard pangry and pain anxiety. I get what pain insomnia is supposed to be. Basically, so much pain you aren't sleeping well. But these are implying, excuse me, that's the next slide. I bounced on without telling you. So pangry, pain anxiety, and pain insomnia. I found those cute in a way, but nonetheless, they're real factors. Next slide. So as the previous slides indicate, pain is not just a physical thing. And in fact, it doesn't have to be physical at all, according to definition and experts. Pain is intertwined as above in this diagram. And so if we look at the diagram, let's pick something, let's make an example. So if we take a look at the wheel of pain above and say, okay, inflammation from trauma, for example, the trauma listed above, could be perceived as nociception, which is pain. Then, depending on the lack or limited social support and poor economic situation, it can contribute to depressed mood, and we move on around the wheel. And without good coping skills, this can be catastrophized and compounded by kinesiophobia, which is the lack of the fear of movement. You hurt, so you don't want to move, and that can turn into exacerbating a poor recovery. So as one can see, the factors can come together into a perpetual cycle. And this is what some have thought chronic pain looks like. So definitions, you'll see 3 to 6 months kind of tossed back and forth between different slides and different experts. But typically, acute pain is thought to be lasting less than 6 months. Many feel like it's less than 3 months. And it's concise, an injury, and usually heals and resolves with either treatment or being healed. The chronic pain, usually lasting longer than 6 months, is a condition that's difficult to treat, often difficult to diagnose, which compounds the fact that you're having difficulty treating it. And the patients generally cannot find lasting relief. So next slide. Now, this is a busy slide, but in the center is a drawing. Many of you may have seen in texts or lectures or books. I know we've got a variety of education approaches on the phone calls, but nonetheless, I almost giggled when I put it in there because it's, I've seen it in at least 10 lectures myself. This is an early depiction of a pain pathway from Rene Descartes in his Treatise of Man paper in 1660s. It states that this fiber running from the foot in the fire all the way up to the cavity in the head is pulled, and heat releases and fluid that makes muscles contract. These are his understanding of what a nerve signal was to the brain, sending pain to the awareness. Now, today we understand that there's neurons and neurotransmitters involved in the communication of pain, and that the person and their experiences matter regarding the pain duration and the pain severity. Now, if you look around the little boxes around this person, the orbs, if you will, there's terms such as central sensitization, peripheral sensitization, descending modulation, cortical plasticity. Um, we've in part, uh, these have been part of the chronic pain discussion for decades. Now, the question we have to ask, is it correct to think this is a sequence or a progression of acute pain to chronic pain? And there's some debate out there, and there's things in between acute and chronic pain and different types of pain. So we'll delve into some of that just a touch, but not to get confused. We do believe there's chronic pain. It's just how do you describe it and treat it may be up for debate. Next slide. So honing in a little bit on acute pain, this drawing depicts at the bottom a skin tissue area that's been traumatized somehow or burned or whatever. And then the peripheral nerve communicates that to the spinal cord, which then goes to the brain, and the different pathways that this happens through. These also have different treatment points that we can achieve. So this pain being communicated to spinal cord and brain, this acute pain should resolve with healing. While healing takes time, there's multimodal pain treatments that can help a patient tolerate this condition. So resting it, icing it, elevating it, anti-inflammatories, neuropathic pain medications like gabapentin, topicals. These days, even your emergency room will offer, in some scenarios, peripheral nerve blocks and IV ketamine. Opioids can be used for acute pain, but it should be after other things have been either extinguished or thought to be inadequate, such as the previous things mentioned, anti-inflammatories and neurologic pain medications. Next slide. So diving into this big, busy slide about chronic pain, healthcare professionals generally think 3 to 6 months. It can persist for months or years. Chronic pain can be a continuous process, such as arthritis, aching and throbbing, often, or an intermittent process, such as associated with episodic migraine. And then it touches on, again, saying the 20% adults experiencing chronic pain in the United States. Now, chronic pain symptoms depend on the cause, but some feelings people with chronic pain describe include aching, burning, stiffness, numbness, throbbing, shooting, and stinging. There are different types of chronic pain. Phantom limb, such as someone that gets an amputation and still feels the aching or painful foot. Then there's neuropathic pain, which typically follows an injury to a nerve that connects the brain to the rest of the body. This can cause tingling and numbness. And then central pain is a form of chronic pain in the brain or spinal cord, and a range of other conditions can cause it, such as multiple sclerosis. The potential causes of chronic pain, moving down the right side of the slide, you see some familiar things listed: shingles, and then things that are familiar to me with disc pathology and low back pain, neck pain, spinal arthritis. These are things that you can point at and see on x-ray or, evaluate through MRI. But there's also people that experience chronic pain that have no apparent injury. And most of us probably heard about fibromyalgia. The exact causes aren't largely known, but the theory suggests that there is an issue with the pain processing in the central nervous system. Next slide. So when we're approaching patients that come into pain clinic, you've got a whole list of issues that could present as right in front of you, right? So is this neuropathic pain or nociceptive pain or central sensitization of pain? And look at the Venn diagram in the middle. It could overlap, right? And there's a significant cohort of the chronic pain population that have this overlapping thing where a patient has spinal disease and diabetes and osteoarthritis, and these things are all building on each other into a pretty, challenging pain scenario for a patient. So as we've discussed, chronic pain is multifactorial. I have patients with varied responses to similar appearing pathology. What I mean by that is I can have a patient that looks like there's not much wrong with their x-ray, and they present with significant back pain or a pain complaint. And then I got a patient that has significant arthritis and bone spurs and what looks like a pinched nerve even, and they're just not bothered by it, right? So among our biggest concerns is how to treat patients appropriately. Um, we want to aid them in maintaining a quality of life and not create new problems such as opioid or benzodiazepine dependence. Next slide. So to add to the list, there's a nociplastic pain. So we've heard about nociceptive pain, the one on top. They're kind of indicating inflammatory or some disease process causing pain. And then the middle one is neuropathic. Again, we talk about pinched nerves or damaged nerves causing stuff radiating down your leg. And then there's this nociplastic, which is modulated by mood and social context and has delayed flare-ups, long-lasting, unpredictable. So we're going to look a little bit into that class of pain for a little bit. Next slide. So chronic pain is challenging to diagnose. Pain is complex. Humans are unique. Pain experiences and injuries don't follow simple rules. We have tools that help us evaluate patients, whether it's the Westry Disability Index, an orthopedic-based thing that looks at patients' physical limitations with their activity, but also compares to disease levels that can help guide us down a path of, is this nociceptive pain, neuropathic pain? And then we get to this nociplastic, and it's got a lot of emotional stuff in it, right? So the international community of pain researchers have indicated mechanistically that this is a distinct type of pain, nociceptive pain. Nociplastic pain. It's different from nociceptive. Nociceptive pain has an inflammation or arthritis, or neuropathic pain has a pinched nerve or a damaged nerve. But with this mechanism, what is the mechanism for this nociceptive pain? It's thought to be augmented by the central nervous system, and sensory processing is altered, and this pain modulation problem may play a prominent role. The symptoms of nociplastic pain are often multifocal. So we have patients come in to the pain clinic and they've drawn on a pain drawing where they hurt. If you've got a person that's circled their knees or circled their lower back, you kind of get an idea of where they're hurting, and it's probably nociceptive or neuropathic if it's radiating down their leg. But if you get someone and they've literally drawn over the entire body, some people will suggest, well, that looks like a fibromyalgia patient. Well, it's also where we're falling into this class of the multifocal pain. It's widespread and intense, and it's out of character to any kind of findings that you have. This class of nociceptive is falling in there, and one of the conditions that it might be is fibromyalgia, right? So we're further trying to describe things. So as a part of a mixed pain state in combination with ongoing nociceptive and neuropathic, such as chronic pain, it's important to recognize this type of pain since it will respond different to different therapies than nociceptive pain or neuropathic pain. Those nociceptive or neuropathic may respond to a steroid injection in the knee or topical anti-inflammatory or surgery. But you get people that have had chronic knee pain and then they get the surgery and they just get worse. That could be a surgical thing. It could be that the knee pain really wasn't the biggest problem. Maybe there's a more widespread issue. And finding best ways to treat something like nociplastic pain, which is generally physical therapy and maybe complementary treatments, CBT, acupuncture, etc. And I hope I'm not bouncing too fast on that, but as we seek for ways to better define and treat chronic pain, nociplastic pain, I believe, is going to be a player. Next slide. Right. So just touching on chronic pain treatments, we want it to be multimodal, meaning not just medicines, not just physical therapy, but a combination of things, maybe even involving interventional, also multidisciplinary. Those again bring in other folks that like the allied professionals that can come in with the CBT, acupuncture, et cetera, to try to treat this patient from multiple attacks, not just medication, right? Although that's where we start sometimes. And you can see on here, there's a list of things in the blue and in the red. So there's an ascending, which means I felt a pain and it rises up my spinal cord and goes to my brain and I say, ouch. And then I want something to treat it. And some of the things that can interrupt that is as listed there. And you'll see ketamine on both of them, which I find interesting because my connections with ketamine and the VA. But then also there's a descending section, and you see gabapentinoids, which help reduce some of the pain signals. Also the SNRIs, which are things like the duloxetine and Cymbalta. So there's ways that the brain can suppress the pain signal, and that's an interesting concept that pain comes in and up, and then the descending component is where your brain and your experiences allow you to say, it's not that bad, or something like that. Maybe somebody's got those coping skills and that helps them do the descending route better without even medications. And we could touch on ketamine later, but I don't want to get too far down that rabbit hole. But ketamine can be quite profound for people with recalcitrant chronic pain. Next slide. All right. So as I mentioned before, there's some things called OSTRI score and Pain Disability Index, the HADS, which is an anxiety and depression scale, helps us try to hone in on what might be going on with the patient. And, I about said not miss something. We always miss something apparently, but best treat the patient. Next slide. All right. So I work at the VA 6 years or so now, and I'm the ketamine director. And we use it to treat recalcitrant pain, but and that means people that have gone through procedures, gone through medications, and even at some point maybe have had a problem with opioids, not necessarily opioid use disorder, but at least they're feeling dependent and it's not helping their pain control. Ketamine can kind of interrupt that process. And even we use it for opioid cessation. But specifically with the veterans, it's interesting because we say roughly 20% of United States citizens or Americans, whatever you want to say, have chronic pain. And in here they say roughly 26%. But double that is what we face in the VA. And a study that looked back over almost 5 million people determined that you have an elevated risk of suicide across all pain types, minus arthritis and neuropathy in the VA. This is successful or completed suicide. So this is one of the biggest mandates we've had at the VA is to try to address that. Mental health has been a huge component of that. But the combination, the joining of chronic pain treatment along with pain psychology has been helpful in treating some of that. I don't want to leave things out, but in my little world, that's what I've noticed. Pain is prevalent. It costs billions of dollars in lost work hours per year, and it's an increased risk of suicide. So, hey, we got to treat chronic pain somehow and effectively, hopefully. Next slide. So, getting into some weeds a little bit here, but it's, is chronic pain a discrete transition from acute pain to chronic pain? And this is where a good bit of the debate is. And some will say, it's not 20% of people in the United States have chronic pain. It's only 10%. And many patients that come into the clinic, one of the things we ask is, when did it start? That's your history of present illness, right? That you have in every physical exam or H&P with a patient. When did it start? How did it start? How long has it been there? What's it feel like? Those types of things. And, many people can't really define it. I don't know. And you and I, each of you may have had an experience where I don't know what happened, but I'm hurting this week. So I did something over the weekend that maybe did it. We try to fill in the blanks. But acute pain is essential function, as we talked about earlier, and it usually heals. So what's the function of chronic pain? So when does pain become chronic? And chronic for humans is usually defined as pain persisting after the healing has occurred. Some might say that's 3 to 6 months after a surgery or an injury. And that's what the IASP it suggested too. It's that 3 to 6 month time frame we've seen recurring here. Difficulty with this is, on the one hand, is that some chronic pain problems such as rheumatoid arthritis or Crohn's disease show evidence of ongoing inflammation. It's an ebbing and flowing kind of pain scenario. So an acute process that waxes and wanes, but we still refer to it as, or it's associated as chronic pain. Another issue with calling something chronic pain is what some have like to describe. What's the chronification process? What's this chronification theory that can explain? Is there one that can explain all chronic pain? Is it due to the transition from acute pain, as I said above? So some evidence has been accumulating about predisposing factors that can predict the development of chronic pain, but they involve like social and financial issues. A change in our thinking is probably indicated about what chronic pain is, because we're reaching past this. A disease, chronic nerve pain, has somehow become ingrained like a scratch on a record, and it's now in the neuroplasticity of the brain become acute because there's so much repetition along that pathway, this ringing pain so long, that's how it becomes chronic. Some believe that's a process. There's probably evidence to that. Is it the only option? And that's what some are arguing is the holy grail would be to find some way to prevent chronification if it exists. There's a variety of acute pain treatments that may help the acute pain, but not preventing chronification of the pain. So where is that treatment that's effective? Is it the mental health side of it? Is it, that the patient's coping skills, which again falls into that realm of mental health, needs to be addressed? So where do we focus interventions for the predisposing factors? But both early, we need to be early in decreasing the chances of the evolution of chronic pain if we believe that's a process. So that concept was poured over pretty significantly by a gentleman named Butler from the Scandinavian Journal of Pain. It's basically pain, chronification. What is the problem with the model? So we could go into a lot of weeds with that. I'm not going to, but I think we've already touched on enough to say saying chronic pain isn't sufficient. We have to pay attention to all the things that make the person that may address the situation. Next slide. All right, so shifting gears a bit to the costs of chronic pain. For example, addiction, drug abuse. Opioids are one of the most effective pain-reducing medications. You don't just use them to make addicts, right? You use them because they work. So there are risks with use and abuse, and then there's the substance use disorder, which is previously known as addiction, if you will. But ultimately, the natural, semi-synthetic, or synthetic forms of of opioids do control pain. Next slide. So who's at risk for OUD, right? Opioid use disorder, substance use in the family, parental substance use, the acceptance of substance use, and ACEs, the adverse childhood experiences, can vary in their presentation, but one can be child sexual abuse. And then there's chronic pain listed, physical illness. Next slide. The neurobiology of the opioid use disorder is what I titled the slide, but basically it gets into talking about pharmacokinetics, which is what how a drug how a body affects the drug, and then pharmacodynamics is how the drug affects the body, right? So one of the reasons people might use a drug is because it has some reward, makes them feel high, or it may be to avoid the aversive issues of withdrawals. So even in this scenario, we have the psychological and social consequences that can build on each other and lead to subsequent use. So the opioid use disorder development is largely based on key components of part of the basal ganglia, the brain, the amygdala, the prefrontal cortex. And in the basal ganglia, it's the reward, the pleasure, the dopamine everybody talks about, right? And then the habitual formation of habitual substance use. The amygdala seems to be avoid the withdrawal symptoms, anxiety, or irritability associated with withdrawal. And then the prefrontal cortex is basically dealing with the neural circuitry involved in the executive functions and exerts control over the individual's cognitive inability to reject the substance. So impulsivity, compulsivity. The failure to resist these impulses and the compulsive use is harmful to self or others. And this is central to the SUD, or the substance use disorder, and other psychiatric disorders. Next slide. So fentanyl. I'm sure everybody recognizes that word. We've seen a lot of this over the past few years, and for good reason. Fentanyl being the synthetic opioid. Its opioid use disorder is chronic relapsing disease influenced by genetics, stress response, and prior experimentation and exposure. People are getting exposed to fentanyl when they intend to use other substances these days, right? So if they buy an oxycodone, or they buy some marijuana, right? They're still getting exposed, and they're going to have that unfortunate exposure. And the physical dependence can develop within 2 to 10 days. And the patient will have some of those withdrawal symptoms by stopping abruptly. But the physical dependence does not mean opioid use disorder or addiction, right? Physical dependence just means your body's seen something and it's missing it now. Like, I miss my caffeine if I don't drink my coffee in the morning, on a different scale, of course. Next slide. U.S. Overdose deaths in 2023 fell for the first time since 2018. Not a great victory, right? But it is a lot of lives when you compare 111,000 to 107,000. And that is an achievement, I presume, but we got a long way to go. I think you'll agree. 3% drop is something, but is definitely not a victory. And then next slide. Want to touch base on some deadly combinations that opioid benzodiazepines is a very common prescribed psychoactive drug, Xanax, Valium, whatever the brand may be, used to treat insomnia and anxiety and seizure disorders. The FDA has a black box warning about additional or exacerbation of CNS depression with use of this combination. Despite this, there's an increasing frequency of opioid analgesics being co-prescribed with benzodiazepines, and this increases overdose deaths. The FDA states that clinicians should limit this combination, and patients should be counseled on the risk of death with that combination. Next slide. So we've got topics of death increased by opioids. Now we cover the reversal agent to some extent. Tennessee Pain Guidelines has recommended to incorporate this into the management strategies to mitigate risks, offering naloxone when the factors increase with the risk of opioid overuse, overdose. the history of overdose, history of substance abuse, higher opioid dosages. So, for instance, if you're 50 morphine equivalents or higher, with or without the benzodiazepine, it's suggested that you would offer your patient naloxone with education on use. And you often want to educate the family members too, because if the person using is the one that's overdosed, they can't really effectively use the naloxone spray in their nose. But the naloxone is a blocking agent at the opioid receptor and usually allows the patient to have some recovery for roughly 45 minutes after a single dose. Now, there's been double dose prescriptions these days because the fentanyl is so strong. Patients are requiring, instead of 4 milligram spray, 8 milligrams, and even you'll hear from some EMS folks, police officers, firemen, that there's they're needing multiple dosages to reverse the patient. That could mean they have a mixed abuse modality too. They may be overdosing on stimulants also. A lot more to say about that and the drug function, but that suffices for today, I think. Next slide. I wanted to put this slide in. This is data from Tennessee. And while in the top left, the CDC in the United States released a news release saying that the overdose deaths had dropped to 107,000 from 111,000 from 22 to 23. And, if you look at this graph to the right, it demonstrates, the different drug classes that were involved. And predominantly fentanyl is the cause of overdose deaths now. And if you look at the numbers real close and do a little math, you'll see that it's a 4-time increase in deaths are directly related to the fentanyl. And if anybody else has input on that, I'll be glad to hear it later. But just looking at that and trying to glean what I wanted to out of it, what I see in it, I remember back in 2013-ish, 2011, 2010, when the opioid crisis was thought to be mainly, and probably correctly thought to be, mainly due to diversion of prescribed opioids, which could include a fentanyl patch, but often was honed in on oxycodone and leftover prescriptions from surgeries and these types of things. And I think a yeoman's effort between multifactorial, government and medical providers, et cetera, have come along to educate and reduce that resource or problem, if you will. And now we deal with fentanyl, which could be trafficked in and out of the country. And next slide. This is the last slide I have on today. And I just wanted to make sure, as we talked about naloxone, we also talk about Suboxone treating opioid use disorder. Methadone has been used as a method for medication assisting therapy for a long time, right? And fewer side effects, better risk profile, meaning maybe not as much respiratory suppression and death associated with buprenorphine use, makes Suboxone maybe a better choice. And wow, how about the DEA? When I don't remember how many years ago it was now, I took the 8-hour course just to get an ex-DEA number. Now, the varied providers that can prescribe this and have it available to patients, they're swung the door open trying to treat people that have opioid use disorder. So a lot of respect to that process. Daily, I use daily, I should say, but often with my patients, I use buprenorphine as a microgram formulation to treat chronic pain. There was some debate over whether it should be used that way. And then as we've gone over the 10, 15 years or so, it's become actually one of the early accepted treatments. If you were going to use an opioid, would be to use buprenorphine formulation, which comes in a patch you can wear a week at a time. It's called Butrans, or an oral form, which you might use up to a couple of times a day, but you let a little film dissolve in your mouth, and it can treat chronic pain, hopefully with less addiction risk and less overdose risk. And was going to say one more thing about that, but I've kind of lost track. So that's kind of closes out where I was going to head today, and open it to questions to hopefully direct things to your interest.
Thank you so much, Dr. Dozier. I think we might have some questions for you before we let you go. I don't see any in the chat right now, but this would be a chance for anyone who would like to speak up for a moment and come off of mute and ask your questions directly while we have the doctor for a little bit longer. Can also put them in the chat if you need.
I have a couple of questions while we're waiting to see if anybody else does.
Yes.
So on this call, Dr. Dozier, you have a combination of frontline providers in a variety of different systems of support, and you have the people, like, for instance, at the state level that might support them, who can get word to them. What would those frontline providers do in terms of, and should they be doing some sort of screening for pain for people that, let's say, come into a brain injury clinic or a domestic violence shelter? Should they be doing any sort of screening? And if they find that there's chronic pain there, should they be where should they be referring first?
That's a good question. I at the primary care level, your primary care provider, ER, if it's an inflection point with a frontline provider, and then as far as the if it's a traumatic brain injury clinic or something along those lines, again, these things are multifactorial. So if you find that the patient could benefit from coping skills or building up in the psychological realm, then that's always a good start. As far as referral to a chronic pain clinic, often your primary care is going to be your first stop to evaluate the patient as a whole. But what people often run into with their primary care is, as soon as they start mentioning pain, they hear, "Oh, you want opioids, and I'm going to send you to a pain clinic anyway," right? So I'm not trying to say that's often or regular, but it's noticeable the amount of time that happens, amount of percentage of times that can happen. So I feel like if you come into contact with a scenario where the patient's just not getting things addressed because their primary care is hands off when it comes to opioids, they can come to a pain clinic and discuss things that don't involve opioids. That's what I would hope that they get early on, is to understand that pain clinic is such an unfortunate misnomer, right? For me, at least, I'd rather not have the patient rolling up saying, "What pill can I take to try to address this?" Although sometimes there may be one. Too often in America, we've come to expect a tablet, to address this, and so in that scenario, of course, the hated one is to just want opioids, right? Now, that being said, there's some patients that, maybe between concomitant diseases, whether they have heart disease or, some reason they can't take NSAIDs, or taking blood thinners, or they have multiple issues that prevent them from taking, anti-seizure medications, they may find that an opioid is a reasonable risk for them. So it would be good that if someone is not finding a reasonable whole kind of whole person treatment for their problems, that pain clinic may be a good way to address that.
Okay.
And I think the Tennessee Department of Health and the pain guidelines have been instructive in that manner. I think it's been a good, I won't say blueprint, but a good effort to guide primary care doctors. The Tennessee pain guidelines wasn't intended just for pain doctors. Actually, it was intended for the general practice providers.
Great. Thank you.
Yep.
Do you see veterans with brain injury in your practice?
Some. I mean, the ones that were number one, absolutely, if you're talking about something as the different continuum, you may run into a TBI. Yes,
Mhm.
absolutely.
And does it, Mhm.
Go ahead.
And does it change your practice or impact it in any way? Like memory problems that you might see or anything like that?
Some veterans will come in and volunteer that, that they need different things because of their brain trauma. But for the most part, we get so many that are on the, could I say, the less severe part of the continuum, that know that it's part of them. They might be a little forgetful, but they still have this ongoing, you know, pain process that we're trying to address. So it's something that's part of them, but not necessarily something that we treat directly.
Mm-hmm. Mm-hmm.
But then we
Okay.
do have some stroke patients, and that can be a quite challenging patient when they have central stroke symptoms or chronic stroke history.
Mm-hmm. Mm-hmm. Thank you. There's a question in the chat. How does one help someone who is trapped and resigned to the cycle of pain and too afraid to break free of a cycle that has led to dependency? Is there a threshold one can pass through where the resistance breaks from realizing there's another pathway to pain relief outside of what the client has determined is the only way?
I love the wording there. I think the patients have to just have the opportunity to have it in front of them so often that at some point they reach it, right? I mean, what would your opinion be on that? I mean, it sounds like um, there's no one point for any, you can't just say there's one target, right? Because I mean, people are individuals. What was the tipping point for you? Oh, it was the divorce, or it was loss of my job, which seems to be a big deal for most people with substance use issues. It's the last thing to go, right? Is usually the job. Um, but I would like to know that too. I would like to know where a target would be most commonly, and maybe I'm missing it off the top of my head right now. But yeah, that's a great question.
Yeah.
I think we just have to be persistent and try to be open to addressing the psychological, the social, and the biological issues that are all at hand. And if there's an opportunity in there when the patient, for instance, in the psychology that we have, the pain psychologists that we have around pain clinic here at the VA, and that's usually a very effective pain clinic, is when you do have that multidisciplinary pain either on that side, or at least they're communicating with the psychiatry, psychology in the treatment plan. But when patients write out, what their pain is and what they want for their life, usually that seems to be a catching point, was where do you want to be? Do you want to continue on this path? Or do you really, you want to be at B, you want to be better, you want to, be providing for your family, you want to be, you know, free to make choices, you don't want to be homeless, whatever the goal may be. Are you going to get there by continuing on this, abuse path? I mean, I think that's a very, very good question.
Mm-hmm. Yeah. And I've seen difficulty where someone has been through some sort of treatment and it hasn't worked. So they've kind of given up completely on, well, there's just nothing to do. So
Right.
it's hard to get them to go back and approach it from a different angle, or with new people or something.
Yeah, rehab, the same 30-day rehab for the 10th time or something. I can only imagine.
Yeah, yeah.
We know some of those strategies don't work, but those are the ones that people continue to get offered. There's folks that don't believe in, medication assisted therapy. They feel like you're just replacing one thing for another. And
Mm-hmm.
it's not as simple as that, because you're also preventing some of the sequelae, right? The drug seeking behavior, the environment that they go in to seek the drugs, the use of drugs that you don't know what's in them. I think there's benefits from what we're trying to do to treat that scenario.
Right, right. I found your slide, where you talked about the ascending and the descending, and that different drugs treat that. I just found that very interesting. I don't really have a question here. I'm not sure I had really thought about it that way. So to know that, like, you can kind of treat it from both angles. And then I think you talked about on the descending side, if you've got good skills, like you've got maybe good family support and you have a meditation practice and things, then it's not that you have less pain per se, but you're handling that pain in a better way.
Yeah, you're living with it somehow, right? Exactly.
Yeah.
Yeah.
And a comment from Mary Lyndon Salter, chronic disease requires chronic and repeated interventions. Multiple rehabs don't mean that rehab is inappropriate. Yeah, I would agree with that.
Absolutely.
Anybody else have questions or comments?
I have a quick question. I was just thinking about people that I know, and if someone is already living with chronic pain and has been for years or even decades, but has not really addressed it other than to sometimes take a ibuprofen or a Tylenol or use ice packs, what's like a first step to get someone into seeking treatment and getting some help?
Yeah, I think right off the top of my head, it becomes knowing that something else exists, right? So your primary care provider or your therapist or someone else can be like, okay, we're working on this part of you, but you've got that radiating pain shooting down your leg that seems to keep you from sleeping and, is pushing your family away because you're hiding in a room to avoid the pain or interactions that might be negative with that. I feel like um, the knowledge that these things exist, that it may be some intervention or some other modality that exists, is going to come from your primary care. Let's say you don't go to the doctor very much. Maybe it's the person that sits next to you at some social event or church or something like that. It's a good question. I know there's things on the internet. Dr. Google can help with some of that too. Like, hey, I got pain shooting down my leg. Well, maybe you need an epidural. It's not as simple as that, but maybe that opens the door to where they figure something else out. It's interesting that we just don't know what we don't know. Now, there's other people that are pretty well deliberate on what they're doing. I'm not going to do anything but A, B, and C. My stepfather, I've talked to him for years about his sciatica. I mean, I keep on bending further forward in my old age. Okay, well, we can't help that necessarily, but we can keep you less miserable, maybe. And he still hasn't done anything except now that he's taking blood thinners, he can't take anti-inflammatories. So it's interesting, and trying to talk to him about physical therapy is like talking to a wall. So even in my own family, I have trouble with that problem.
Thank you.
Sorry, there's not an answer there.
No, I think that was a great answer.
Uh,
I almost got something out of the previous question that Q had that was about addressing someone's problem with substance use for chronic pain. The example I have, the person doesn't use anything usually for pain, but it's very similar in the answer that you gave him, that um, it's deciding where is your stopping point and what do you actually want and where will you begin to make change. So I appreciate it.
Any other questions?
Looks like we have a couple of comments here in the chat.
yeah, I saw the motivational interviewing just pop up, and I went through a seminar with the nurse practitioner I work with up in Clarksville, and we were at the VA, and the VA has a talk about nociceptive, like we were talking about earlier, how it's not necessarily a tissue damage kind of problem. It's maybe that fibromyalgia class. And the motivational interviewing, that was a recurring point as far as trying to help patients maybe ease them down a direction and give them some direction in what they're seeking. But I may have used the wrong words in some of that, but I agree with the motivational interview.
I can read this follow-up from Q. I feel so helpless with my client who has extreme allergies to certain meds and managing pain. They literally have violent adverse reactions to meds and forced to take them to the emergency room with dire consequences. I don't know pain management well enough to confidently guide and support the client toward managing pain. This client has been tagged, so wherever they go, they are deemed a drug seeker and call me for help. As he's carted through the passing parade of providers who throw him away.
I have patients that, again, like I was saying earlier, they present to their primary care, and as soon as they start mentioning pain, it just sets off a lot of defensive barriers from the provider perspective, from the provider patient's perspective of the provider, maybe, and the ER isn't immune to that. So even if they go to the ER, for instance, like people with severe migraine that's not being successfully treated, they may get a cocktail of a muscle relaxant and Toradol or something injected if they can tolerate those. But otherwise, they may be seen as just a pain seeker. Even the patients start telling happen. I can go sit in the ER for 3 hours and get nothing done. This is a quote, not my general feeling about it, but
Right.
ultimately, I can totally sympathize with that scenario that you're saying. I've got patients with numerous allergies. If they've got an addressable pathology, then there's something other than medication out there for them, right? So, and I know we spent a lot of time kind of y'all listen to me ramble on about how some of these pain scenarios aren't associated with a concise pathology or damage or trauma or something to treat as far as an intervention, but some are. And then regards to patients that may have multiple medication issues, then some of the complementary medical treatments may be helpful, whether it's acupuncture or even massage for some, chiropractic, etc., may be a benefit to them, depending on what the pain symptom is or situation.
Great. Any other questions? Well, you can come in at any time with questions. I was just going to talk about a little bit about chronic pain and brain injury to talk about that intersectionality. So we know that with brain injury, pain is the most common chronic medical condition reported by people with traumatic brain injury, and over half of the people with a TBI develop chronic pain. They have more frequent headaches that may be medicated. They're more likely to be prescribed opioids. They have common problems that follow a brain injury, like poor judgment and memory and increased impulsivity, make it harder to self-regulate substance use and make overdose more likely, and they make it harder in our practice to when I was worked in a brain trauma clinic, it was harder for them to manage like a medication schedule and to remember whether they had taken it. And the pain can also exacerbate the brain injury symptoms, that it's really hard to pay attention when you're in pain. It's really hard to be remembering, paying attention. Usually that's attention. You're paying attention enough to be able to remember something. It can decrease your judgment. So it can really impact those brain injury symptoms. And people with brain injuries are 11 times greater risk of accidental overdose. Traumatic headaches, like I mentioned, are one of the really big deals following a brain injury. So chronic post-traumatic headaches, which is like 12 months after the injury, the rates reach up to 95%. So it's just a lot of people with brain injury are going to have headaches. And usually, often the chronic pain is often inversely correlated with the severity of injury. So often the people who have mild injuries are ones who have the most severe pain. And then one last one. Okay, why do they have this pain? It said that it could be from their neck. We see that a lot. If you think about a traumatic brain injury, the way those occur, car accidents and falls downstairs and all kinds of big events like that can really make the neck get it out of position, which then sets off inflammation, and the muscles can be out of alignment. The muscles are then reacting to the misalignment, and so neuroinflammation is another pathway. Damaged pain pathways is a question. Estrogen disruption and psychology. So conditioned pain avoidance. You learn that you go to work and the lights are really bright and that hurt your headache, so you decide you can't go to work anymore. You go to Kroger and there's so much noise that spurs a headache, and you decide that you can't go to Kroger anymore. So then your world shrinks. Now you're bringing on depression and potentially anxiety, and that, like Dr. Dozier talked about, also compounds things. And of course, stress can compound things as well. Any thoughts on, so I've just shared about how brain injury impacts, or how pain impacts brain injury. Anyone else share? Will anybody else share about how their area is impacted? What do you see from pain in the folks that you treat? First, is this an issue? I'm going to say yes for all of you. But anybody have any comment about that? Anybody feeling brave? It's a safe group.
Well, I think one of the get my mic down here. One of the things that I've seen is people, especially with the rates of addiction here in Hawkins County, they'll wind up taking anything that they can that'll alleviate even the least bit of suffering, and the mix of the drugs winds up. I think that we have a lot of brain injury as a result of the drug use. And so the drug use is causing the brain injury, which is causing the pain, which is leading to more drug use. I've seen so many people just get turned away because they're medication seeking. And of course they're medication seeking because they're in pain.
Right.
And so it's this vicious cycle that just kind of sucks them down in this vortex that they can't get out of. And the next thing you know, they're 88 pounds and picking their sores on the street, and nobody will help them at all then. And so how do we get them out of this cycle? What are the answers? The resources, I mean, we've talked about this before. The resources are so thin here. What do we do for them?
Yeah.
And that question goes to anybody.
Yeah. Rick, you want to take a shot at it?
Yeah, I've been a brain injury service coordinator for 24 years. And of course, you hear headaches a whole lot from your clients. And I've found that most people who have had a significant brain injury also have some vision deficits. And seeing a neuro-optometrist, which is an optometrist that's had specialized training in people with traumatic brain injuries, I think that's the one doctor that I've heard that I've helped them more than anyone else, having your vision screwed up. And once you have it corrected, it can really help with headaches. That's just been my experience.
So keeping that in mind with the headaches. That's a good comment.
Thank you, Rick.
Anybody, any other thoughts on what John said? How do we help people at that point? And John, you're in a rural county?
Yeah, Hawkins County is very rural.
Okay. So I'm not sure that this is going to be an answer, but in September, on September 5th, We're going to be bringing up, we're going to start to switch into the social determinants of health sorts of categories, and we'll be talking with rural health first and addressing some of those issues. But yeah, rural is hard for probably all of the different areas. Yeah. Any other thoughts, suggestions, questions?
The picture he painted about that scenario is so troubling, and there, you think about, or at least thing that comes to mind for me is the mental health availability in that process, and it's just there's not enough of it.
Yeah.
And if you could break one of the, you think of it kind of like legs of a table. If you could, kind of get one of those things, get control of one of them, like the mental health side of it, and then could get a hold of other components of that person's problems, then maybe you could make an edgeway in. But if you can't get a good hold on anything, whether it's the mental health that then leads to job loss, that then leads to the exacerbation of the drug abuse, and then wow, I don't know. But I would like to touch on one thing you mentioned back about the traumatic brain injury and neck. It's a very common scenario to have kind of this chronic whiplash syndrome, the upper part of the neck, especially the C3, C4 vertebral intersection, where there's a joint like a knuckle. There's a nerve that comes out, and that's where your occipital nerve originates and then goes up the back of your head, wraps around toward the sides of your head over the ear. A very common scenario. There's interventions there, whether it's chiropractic, or we even do something in my realm called radio frequency ablation, where we can go out and burn that little nerve, and people may get anywhere from 6 months to 2 years of pain reduction in that area. So definitely some things that can be addressed when we can find the problem.
Right.
Yeah, I'll stop there.
Yeah. No, thank you. Thank you. Any other thoughts, questions, comments before we turn to the resource pages?
Yeah, I was just going to say, I put it in the chat, but we do often see an increased risk of suicide death in patients or individuals who have traumatic brain injuries and chronic pain. But unfortunately, in the healthcare system, it is not, those patients are not necessarily assessed for suicidality or at the rate that they should be, especially in specialist offices. But it should, that tends to get overlooked. And it's that area that we are hoping to push in the healthcare systems, is making sure certain in those specialist offices that those assessments get completed.
And Harper Grace, tell me what system support you're in?
Mental Health America of the Mid-South. I'm our Zero Suicide Initiative Director. So we are implementing zero suicide in healthcare facilities and not just behavioral healthcare as traditionally is done.
Yeah, we at the VA, the pain clinic is one of the sites that's required to ask, at least the initial screening for suicide at every visit. The EDER here is also another one in addition to mental health. So I wish that could expand out to the larger society.
Right. Right. Anything else? Anyone want to share, ask?
We have another comment here in the chat. I'll gladly read it. Shauna Schilling is saying much of chronic pain presentation can have a source point in neurodevelopment and attributed to a kind of adaptive mitigating biology. Gaber Mate and Amy Appigan, I'm going to pronounce that wrong, Appigan, are a few leaders in this research. A client's sense of self-efficacy and sense of capacity for coping and healing are often impacted by early life experiences. Think epigenetics In essence, a multimodal approach, including psychotherapy, could be essential to helping clients get to where they want to be. This therapeutic work would include looking at attachment, trauma impacts, trauma as in wounding, not just what we tend to think of as trauma, ACEs, traumatic brain injuries, and even the formation of our identity negative cognitions, limiting beliefs and the self-concept encoded in the body. Hope that makes sense. We are one system, much lends to the presentation of pain, and it takes much to heal it. Thank you.
All right. It's interesting, all of the different connections we've talked about today with all of the different systems of support being having different connections here. I'm going to share. Jen, do you think we have time to go through the
Yeah.
Okay,
Just
great.
quickly.
So in our last few minutes, take it away, Jen.
Sure. We're having a little look here, a preview at our chronic pain resources pages. I say pages because it's never just a page anymore. We have a lot of good stuff. But you can see when you receive this probably next week when we send out our follow-up email, that this will give you some basics that we covered today about the difference between acute pain and chronic pain. And some of the same things that Dr. Dozier covered as far as those statistics that for every 10,000 people with severe pain, there's only one board certified pain specialist, and that 20% of the adult population are living with chronic pain, and many of those with more than one type. I think there's one more. Oh, okay. And here's just a glance at the second page. Everyone will see this and be able to click on all of these things, but we especially wanted to point out just a few special items in here.
And Dr. Dozier, if I can just interrupt you, Jen, for a
Sure.
second. Dr. Dozier, if you see anything on here that you think that we've left off, please let us know and we'll include it before we send it out. If you think that there's something here that is not, you don't think should be sent out with it, please let us know that as well.
Thank you, Wendy. Yes,
Okay.
we did a lot of, I can say for myself, I did a lot of learning brand new things in putting together the resources in this particular set of resource pages. So a lot of this was very new for me, and I learned more than usual. And then I just am really impressed with how interesting and how much I learned just now from Dr. Dozier that was totally kind of different than what I was looking at and gathering these resources for all of us. So really appreciate both sides of this that we've gotten to share with all of you today. Just a glimpse at one of the infographics that I really liked, chronic pain and stigma. There's many of us in the groups that we work with deal with stigma and with people sort of misunderstanding a condition or a disability or situation that the people that we serve are in. And this is from the National Institute of Health, and we just wanted you to kind of get a glimpse at some of these things. We're sending a Word document or a PDF, and it's full of lots of text and lots of links, but they all go to helpful, beautiful websites and things that you might just want to print and share or post or send on, even if it's just that one piece that you can get in front of the people that need to see this. And here's another glimpse. One of the great resources that we found that I was really excited about was from the Model Systems Knowledge Translation Center. Not only do they have resources about traumatic brain injury and chronic pain, but they have fact sheets. They have lots of specific information. This is not a topic that's so easy to find good information all in one place that combines traumatic brain injury and chronic pain. And I was able to find it here. So this is a glimpse at one of the many fact sheets that's on the link that we've provided on the resource pages. But I really liked another piece that they included too. They were info comics, and this was my first time seeing something like this. It kind of reminds me of the little booklets that you used to see, or maybe still do, at the health department, that are drawings, and sometimes they're just very true to life. They're kind of makes something that's not very fun a little bit more fun to understand and to learn about. So I highly recommend checking out this website and bookmarking it if this is an area that interests you. And here's just another little glimpse of some of the things that they offer and just how detailed this one section of this website is, that when you go there, you'll see so much. And wow, we found a lot of good information too about trainings. And I just wanted to bring this up because I think it's an important concept. Probably many of you have heard of this before, but if you haven't, spoon theory is something that's been around and been talked about for about 20 years. This was developed as a way for a person with chronic pain to sort of help other people relate and kind of give a visual, if you will, to what it's like to live with chronic pain. So this infographic will kind of break it down if you want to look at it later and understand it or share it with someone else. But essentially it's saying, I have this many of something, and they're using spoons as this example. I think the actual original experience was in a diner, and she just grabbed things that were handy to be able to describe how this went. But when you're living with chronic pain, you have this finite amount of spoons to accomplish certain things and to exert energy to accomplish things. And for different people, it takes so many of those spoons. And when you've used them for the day, you've used them for the day. So you might have to go into your day saying, I can only use this many. And if you have a day that you're very busy and you have more things to accomplish, you kind of have to budget out your energy level. So I really found it to be an interesting way to understand. And if you have people that you're working with that live with chronic pain, if they're not familiar with this, this is a tool to help them explain to others who do not get the pain and don't understand the things that they cannot see.
And we use this in the brain injury clinic too, to explain, it was so similar, the limited amount of energy that you had for the day. And so whether pain was or was not a part of it, it was still applicable.
And
Great. So
I'm sorry,
I'm
I
sorry.
want to mention
ahead,
one more
Jen.
thing, just just to point out, the US Pain Foundation was an excellent resource throughout the different categories that we try to give you the resources in. So that's a really good one if anyone wants to join their newsletter. If this is a subject that interests you, you'll get information about training, about events going on. I joined it in creating this, and I'm already surprised at how many good things I've received. Okay, Wendy.
Great. All right. And so probably I'll keep going, because at this point it doesn't matter, Jen, if people who are listening on archives, they can listen to this next step too. So at this point, you're going to get those resource pages. Please send them out, send them wide and far. Let people get this information, especially frontline workers. Like I said, there's a newsletter ready summary that you can just drop right into your newsletters, or you can email it, just forward it on. And then in the final moments, if you can just take our 1-minute survey. Now, you will also get a certificate for filling it out. So if you can, many of us can use this as a training as a CEU. So you can get that certificate. So share it with others who might be able to do that as well. This will be posted to the website in a few days, and they can listen there, and they can get the certificate for participation. And our next meeting, like I said, is on rural health. And that's on September 5th from 1 to 2:30 Central. And Dr. Dozier, I want to thank you so much. This has been extremely helpful, and I think you can hear that it was extremely helpful to and interesting to everyone here today. So we really thank you for taking the time to share that information with us. And thank you, everybody. And we'll see you in September.
Thank you all.
Thank you, ladies. I'm gonna hop off of here and I will talk to y'all soon.
It's good to
Carrie.
see you, Carrie.
See you. Bye.
Hope to see you two in person. I hope to
I
see
hope
you
so.
two in person in September.
Great. Is
We've
that
got a
John
train. We've got a
that-
yes, it's John.
at
yeah.
Frontier?
Yeah.
Awesome. We'll be
Good,
there.
good.
Yeah.
Yes.
Yeah.
Yes.
I plan on being there in person. So
Great.
Excellent.
Looking forward to
that's
it.
Yeah, be sure
that's
to say hi.
exciting. Yeah, that'll be great.
Yeah,
All right. I'll
thank
see you guys then.
Bye-bye.